Afternoon. I'm Dr. Khushbu Mahajan, dermatology educator at PrepLadder, and today we will be talking about a short topic in dermatology, which is bacterial infections of skin. Now, though this is a short topic, but quite a scoring topic and quite important topic. So, what we will be covering in this session, we'll be covering the major bacterial infections related to dermatology, which are asked in the exam. So I hope you're able to hear me and you're able to see me. In case there are any glitches, feel free to write it in the chat box. Also, I would encourage you to ask questions or make this session more interactive. So moving on, when we talk about bacterial infections of the skin, first we should be knowing that what is the normal flora of the skin. So when we talk about flora, the flora is of two types. There can be a resident flora and a pathogenic flora. So what do I mean by resident flora? Resident flora is a flora which is present in my skin throughout, and it is protective. It is basically a good layer of microorganisms which covers my skin and protects my skin from getting inhabited by bad microorganisms. So these are good microorganisms, and they help protect my skin. Some examples of resident flora would be Staph epidermidis, Pityriasis P. ovale. Then Malassezia is also a resident flora in the skin, but it is not a bacteria. The second important kind of flora that we should be knowing is pathogenic flora. Now, this is the flora which is transiently present on my skin, and this is the kind of bacteria which causes infections in the skin. Two most important pathogenic bacteria for me are Staph aureus and Streptococcus pyogenes. So these are the two main bacteria which commonly infect my skin and cause various bacterial infections. So the duration of this session would be approximately 30 to 45 minutes. Now, what makes me prone to developing a bacterial infection of the skin? It can be bacterial infections of skin can happen due to a lot of reasons. If a patient is diabetic, if a patient is immunocompromised, then if my skin barrier is hampered due to any reason, it will make me more prone to bacterial infections. Then bacterial infections are more common in monsoon season because in that season there is more colonization of pathogenic bacteria in human skin. What are the causative organisms? I already told you. Now, how do I classify bacterial infections of the skin? Now, bacterial infections of the skin is also called as pyoderma. So, pyoderma is another term which we use for bacterial infections of the skin. Now, nobody is going to ask you this classification in exam. This just helps you to memorize things easily and to understand things better. So broadly, I divide my pyoderma into follicular type and non-follicular type. What do I mean by that? What do I mean by follicular type of infection? Follicular infection is something which would infect my hair follicle and the area surrounding it. Whereas non-follicular infection would be one which is not limited to hair follicle involvement. It can affect the other parts of my skin also. Clear? Now, when we talk about non-follicular infections, they can be either localized or they can be diffuse, right? In localized, it's basically my impetigo and ecthyma, out of which impetigo is more superficial and ecthyma is more deep. So both impetigo and ecthyma, we'll talk about each one of them in detail. Both impetigo and ecthyma are localized to a particular area, and so they're called as localized infection, and they're non-follicular in nature. If we talk about diffuse infection, which is non-follicular, that is further divided into erysipelas and cellulitis, right? So just know the names. We will talk about each condition and then you will understand it better. We'll talk about follicular infections when we reach there. Now, coming to the first and foremost bacterial infection, which is impetigo. As I already told you, this is non-follicular in nature and is localized and superficial, so as to say that it is mildest of all the bacterial infections. Also, impetigo is the most common bacterial infection that you see. Now, impetigo is further divided into two types, bullous impetigo and non-bullous impetigo. Non-bullous impetigo is also called as impetigo contagiosum. Contagiosum is something which spreads. So non-bullous impetigo spreads contiguously. Now, why do I classify it like this? Both impetigos are form of impetigo, but in bullous impetigo, you see formation of bulla. Non-bullous impetigo will also see formation of bulla, but then the bulla ruptures very soon. And so what you predominantly see here are crusted erosions. Clear? So both of them may start with bulla. With bullous impetigo, you predominantly see bulla. In non-bullous impetigo, the bulla ruptures to form crusted erosions. Also, this is the more common type of impetigo that you see. Clear? Now, how do you differentiate these two? So this is my bullous impetigo, where I'm seeing bulla, and this is my non-bullous impetigo, where I see crusted erosions. Now, can any of you tell me what is the characteristic feature of the crust in non-bullous impetigo or impetigo contagiosum? The crust is very, very particular. Please tell me what kind of crust do you see in non-bullous impetigo? Now, bullous impetigo is usually seen in newborns, whereas impetigo contagiosum is more commonly seen in toddlers and in children. Bullous impetigo is predominantly caused by Staph aureus, whereas impetigo contagiosum can be caused by both Streptococcus and Staphylococcus. But out of these, in developing countries, Streptococcus is the more important cause of impetigo contagiosum. Great. So, Dr. Rachit, you are absolutely right. What you see here is honey colored crust. And this is a very, very important feature of impetigo contagiosum, and that is what is usually given to you in the exam. So they give you a face of a child and they tell you that there is honey colored crust, or you see crust like this. This is very, very characteristic feature of non-bullous impetigo or impetigo contagiosum. On the other hand, bullous impetigo presents with golden colored crusts. Okay, next question. What complication is non-bullous impetigo associated with? What is the common not very common, but the complication which is associated with impetigo contagiosum, which has been also asked in the exam? So any idea? I'll wait for your inputs. Now, bullous impetigo and impetigo contagiosum both can present with lymphadenopathy because it's a bacterial infection. So localized lymphadenopathy will be present. So broadly speaking, bullous impetigo you see in newborns as bullae, as golden colored crust. And also very importantly, do you see this bulla? It looks like a hypopyon or a half moon, where the fluid gets accumulated on the lower end of the bulla because of gravity. Whereas non-bullous impetigo presents in toddlers on the face as these honey-colored crust. And this honey-colored crust have a tendency to spread, and that's why it is called as impetigo contagiosum. Very good, Dr. Sangeeta, you're absolutely right. So the complication which is uncommonly seen with impetigo contagiosum is post-streptococcal glomerulonephritis. This is very rare, but it is a possibility here. Clear? The next important question comes, what is the target? Why are the bulla being formed? The target in bullous impetigo is actually desmoglein 1. And if you remember our topic on immunobullous disorders, desmoglein 1 is something that is present on the upper layers of the skin. And so when desmoglein 1 is targeted, you get very superficial bulla. So this is another important question that has been asked. The target in bullous impetigo is desmoglein 1, and that is why you see formation of these bulla there, right? Then what is this? When you get an image of impetigo in any form, sometimes they'll give you this. Now I told you the causative organism is staph or streptococcus. So on gram stain, you see gram positive coccobacilli, and these are present in clusters, and these are typically called as grape like clusters. So on gram stain, you see these gram positive cocci which are present in clusters called as grape-like clusters. So sometimes they may give you this gram stain image, and it would be easier for you to identify that we are talking about impetigo. Is the audio still not clear? So management of all bacterial infections I'll discuss in the end. But broadly speaking, since impetigo is a localized kind of infection, it is superficial kind of infection. So here we would mainly use topical antibiotics. We do not need oral antibiotics in this case, right? Okay, some of you are saying it's clear, some is saying voice is cracking. I'll try to be more clear and louder. Now coming to the next kind of bacterial infection, which is ecthyma. Now, ecthyma is again non-follicular. This is also localized, but is deeper than impetigo. So it goes a little deeper. Now, ecthyma is also caused by both strep and staph, but more commonly it is caused by streptococcus. Commonly on buttocks, thighs, and legs. Now, more importantly, you should know how does it present. So this is how ecthyma presents with. Ecthyma will present with, it will start with a small papule and pustule which burst to form necrotic heaped up crusts. So typically, patient will have one or two these lesions on buttocks, on thighs, on legs, and this will typically have this necrotic heaped up crust with some surrounding erythema, which is typical of ecthyma. So ecthyma has erythema and necrotic heaped up crust, and there will be usually single 2 to 3 lesions. They are localized, they are non-follicular, but they are a little deeper, and that is why you see these necrotic crust. This is caused by streptococcus more commonly than staphylococcus. Clear? That is what you need to know about ecthyma. Coming next to erysipelas and cellulitis. Now, these are also non-follicular infections, but are more diffuse. They are not localized to a particular area. Now, in this category, we have two infections, erysipelas and cellulitis. Out of this, erysipelas is superficial and cellulitis is deep. Now, when they want to give you a question on erysipelas and cellulitis, this is the common presentation that they give you, and you have to differentiate broadly between these two. So both these conditions will present with warm, tender plaques. So typically the patient will come to you with warm, tender plaques, which are usually present on legs. They can be present on face. They can be present on upper limbs as well. And along with that, patient will have constitutional symptoms like fever, malaise. Now, this is a more diffuse infection. So now my constitutional symptoms have come up. They have not come up till yet. So fever, malaise, joint pains, along with painful plaque, which is present on limbs or on face. Now, when you look at it, this looks something like this. We'll go back to the previous image. So, erysipelas is something which infects only my superficial dermis, whereas cellulitis is something which can go up to subcutaneous tissue as well. So, coming here, this is erysipelas. Erysipelas is, you can see, is limited to upper dermis and superficial dermal lymphatics, whereas cellulitis is very deep. It can go up to subcutaneous tissue. That is the difference between erysipelas and cellulitis. But how do you, when you see the patient, how do you differentiate? So since erysipelas is superficial, here my plaque are well demarcated. They are well demarcated because they're superficial. So they'll have a well demarcated margins, whereas cellulitis being deep, going up to the subcutaneous tissue, is more diffuse, not demarcated. That is the major difference between erysipelas and cellulitis. So both of them present with warm, tender plaques with constitutional symptoms. But when you examine the patient, erysipelas will be more superficial, so it will be well demarcated, whereas cellulitis will be more diffuse and non-demarcated. Another thing that you can see in erysipelas is called as million-ear sign. What is that? Now, since my ear does not have any subcutaneous tissue, so in erysipelas, you see commonly ear involvement. So if you see some warm tender plaque on face which is going up to the ears, it is most likely erysipelas, because cellulitis does not happen in ears because it does not have subcutaneous tissue. Clear? So well demarcated erysipelas, non-well demarcated, it will be cellulitis. Again, now here, again, I'll discuss the treatment, but since cellulitis and erysipelas are going up to the dermis, going up to the subcutaneous tissue, here you would need oral antibiotics. So clear? Now that is why we need the classification. Now we understand that when we are going to a diffuse kind of infection which is spreading, I will need oral antibiotics. But if it is something which is more superficial, more localized, even topical antibiotics would work. Clear? Then there is something that you should be knowing, because this has once come in the exam. Now, streptococcus can also affect the lymphatic vessels of subcutaneous tissue, in which case I call it acute lymphangitis. When my lymphatic vessels are linearly running on the skin, it will present with erythematous, linear streaks of varying width, which is extending from some local lesion towards the regional lymph node. Now, what happens here is, suppose you have a little infection, paronychia, suppose, of the nail folds. From that, my infection spreads to the lymphatic. So I will have a focus of infection here, and from there, the infection would go linearly into the lymphatic gland. So starting from the origin of the lesion, there is a linear erythematous tract that you see, which is warm, which is tender. So this is acute lymphangitis, and this was a question which was once asked in NEET PG exam. This is warm, tender, enlarged. Again, would require oral antibiotics. Right. Next, coming to pyodermas, which are follicular. So this was all non-follicular, not limited to the hair follicles. Now we are coming to follicular infections. As I told you, follicular infection would be something which is limited to the hair follicle. Now it's very easy to understand again. Follicular infection can further be divided into folliculitis, furuncle, and carbuncle. And this folliculitis can further be superficial and deep. Again, looks confusing, very easy to understand. So see, this is my hair follicle. If my infection is limited to the hair follicle, I will call it folliculitis. If it is present in the superficial part of hair follicle, I will call it superficial folliculitis. If my infection is extending deep into the follicle, I will call it deep folliculitis. Clear? So folliculitis, superficial and deep. Now, if along with the hair follicle, my surrounding skin is also getting infected, that means along with furuncle, along with follicle, my perifollicular tissue is also involved. Then I call it furuncle. Furuncle is when perifollicular tissue is also involved. Then what is a carbuncle? If, see here, there are multiple hair follicles which are affected together. So carbuncle is when multiple contiguous hair follicles are involved. Clear? So these are my follicular infection. Easy to understand: folliculitis, furuncle and carbuncle. Folliculitis when follicle is involved. When perifollicular tissue is involved, it becomes furuncle. Multiple contiguous hair follicles being involved, it is carbuncle. Now, this is how my superficial folliculitis would look like. Very, very minute since it's superficial. So very, very minute superficial pustules which can be present along the hairlines, along the face. This is my superficial folliculitis, would typically require topical antibiotics. There is a form of superficial folliculitis which is asked in exam, which is called as Bouchard's impetigo. Now, it's a misnomer. This is not an impetigo, and that is why they give you this in the exam. So, Bouchard's impetigo is actually superficial folliculitis caused by Staphylococcus aureus. Now, remember one thing, all kinds of follicular infections are caused by Staphylococcus aureus. So, there is no confusion there. In non-follicular, we were talking Streptococcus, Staphylococcus. Follicular, all infections are caused by Staphylococcus. So this is a Staphylococcus aureus superficial folliculitis in which you develop pustules which can involve scalp, hair margins, and even on legs you can see that. So just remember, Bouchard's impetigo is Staphylococcus aureus induced superficial folliculitis. It is not a type of impetigo. Deep folliculitis would be something that you see on the beard area. You can even see it on scalp. Here I will have deep follicular lesions. So in follicle, you see erythematous, deep pustular lesions which are localized around the hair follicle. So these were so superficial. You see this? They were there around the villus hairs. So very, very small. Now here they are mostly present in the terminal hair and they are present as these erythematous, painful, deep-seated follicular lesions, right? And they can be present on beard or scalp. When they are present in beard, we call it psychosis barbae. Another misnomer. Psychosis is something which is related to fungus, but please remember psychosis barbae is a misnomer. It is a bacterial infection of the beard. When it happens on the scalp, I call it folliculitis decalvans. Clear? So this is how deep folliculitis will present. This is deep folliculitis of scalp. Now, perifolliculitis, as I told you, these furuncle and carbuncle are when folliculitis and perifollicular tissue is involved. So this is my furuncle. You see this? This is the follicle which is involved and surrounding it perifollicular tissue is involved. This is commonly also referred to as Baltod. So people would come to you with very, very painful and when you feel there is tenderness, there is lot of inflammation that is there. This is furuncle. It will always require oral antibiotics. Now, what is this? This is carbuncle. You see this? You have multiple contiguous hair follicles being involved along with lot of perifollicular inflammation. Carbuncle is very common in diabetics, right? So you should be able to identify these infections. Again, carbuncle would require oral antibiotics. Clear? Now, just to finish the list, these were all follicular and non-follicular infection. There are certain toxin-mediated dermatosis which you should be knowing about. The commonest which is asked is staphylococcal scalded skin syndrome. Now, what do I mean by toxin-mediated disorders? Now, these bacteria, both streptococcus and staphylococcus, they also release certain toxins. And per se, because of those toxins, you can have certain dermatosis. The commonest among them being staphylococcal scalded skin syndrome. Commonest as in this is what is asked to you in the exam. So also called as SSSS. Now this is mediated by Staphylococcus, as the name suggests, which releases a toxin called as ET1 or exfoliative toxin. And this toxin goes and targets my desmoglein 1. So what happens typically in this kind of infection is it will usually be seen in newborns or infants. Now it will start with some bacterial infection, which can be in the ears, as folliculitis, whatever. So some small focus of bacterial infection happens. Now when that bacteria affecting that area, this bacteria releases this ET1 or exfoliative toxin. This ET1 goes into the bloodstream and goes and binds to desmoglein 1 in the skin. And this leads to denudation of skin because ET1 goes to blood. From blood, it travels to skin, binds to desmoglein 1, and what it leads to is this. So it is usually a newborn or an infant who's admitted, and you get a referral and you go there and you see that there is denudation of skin or peeling away of skin along with fever, constitutional symptoms. There is redness of the skin, and there is a history of some focus of bacterial infection, right? So this is called as staphylococcal scalded skin syndrome because my skin is getting scalded because of release of toxin called as ET1 or exfoliative toxin, which binds to desmoglein 1 and leads to peeling off or denudation of skin, commonly seen on newborns, right? So this is a toxin-mediated dermatosis. Clear? So I hope you're able to get what I'm teaching and you're able to understand. And I hope my audio is better now. So, right. So these were my pyodermas, which were caused by staph and streptococcus. Now, there are certain other bacteria which also can infect the human skin. The one of the common ones being Corynebacterium infection. Now, Corynebacterium causes three kinds of infections in human skin: erythrasma, trichomycosis axillaris, and pitted keratolysis. So I hope you're able to hear me, students, and I hope you're able to follow what I'm teaching. So now these are three important infections which are caused by various species of Corynebacterium. Corynebacterium have different species. Now Corynebacterium typically affects healthy adults, and it is more commonly seen when the environment is more hot and humid. And another important feature of Corynebacterium infection is that it's usually asymptomatic and sometimes very, very mild pruritus is there. So it's not very symptomatic infection. It is affecting my healthy adults and it is seen in hot and humid climates. Now, it can affect various body sites, but the most common site which is affected is toe webs, which is followed by groin creases. So commonly, this is a question which has been asked. Corynebacterium infection is most commonly seen in toe webs. This can also affect the groin area. It can also affect the axilla, right? The most commonest Corynebacterial infection which is asked in the exam is called as erythrasma. Erythrasma typically is seen in toe web space, axilla, and groin, and it typically present with asymptomatic or mildly pruritic erythematous, lightly scaly, well demarcated plaques. Right? So let's look at how it looks like. So look at this. Erythematous, well demarcated, mildly symptomatic, mildly scaly plaques, which can be present on axilla, groins, or toe web space. Now, a very, very important thing happens. Like when you see this, you have to differentiate it from tinea, because commonly tinea will also present with erythematous scaly lesions. So how do you differentiate tinea from Corynebacterium infection? The best test to do that is Wood's lamp. Now, when you do a Wood's lamp for Corynebacterial infection, especially erythrasma, you see this coral red fluorescence. You see this coral red fluorescence, and this is the most diagnostic test to differentiate erythrasma from other kind of infections that can occur in this area. So when you do a Wood lamp, the Corynebacterial will typically emit a coral red fluorescence, and this is how it looks like. So another other important differentiating features are they're more well demarcated, they're less scaly, they're less symptomatic. Tinea would be usually more symptomatic, more scaly, but this is the one which is most diagnostic of all, right? So this is a very, very important question that is asked on Wood's lamp. You see coral red fluorescence with erythrasma, the sites which are affected. Typically for erythrasma, you will use topical therapies. Again, antibacterial like fusidic acid. We'll talk about these agents. If it is very, very extensive, you can go for oral options also. The second important infection caused by Corynebacterium is trichomycosis axillaris. Now, this is a misnomer again, because mycosis means fungal, but this is not a fungal infection. It is a bacterial infection caused by Corynebacterium. So trichomycosis axillaris, as the name suggests, would affect my axillary hair. And it presents with these soft, adherent nodules on axilla. So you see these soft, adherent, asymptomatic nodules on axilla, and this is trichomycosis axillaris, again caused by Corynebacterium. So you should just be able to identify this image. Next common infection is pitted keratolysis, third infection caused by Corynebacterium. As the name suggests, you would see pits here, and that happens because of lysis of keratin. Now, this is caused by a species of Corynebacterium, which is Micrococcus sedentarius. Micrococcus sedentarius is a species which causes it, and typically it looks like this, very, very classical image. So when you look at the feet of the patient, it typically present on feet of the patient, you see these pits, you see these holes, and you see maceration. Now, this pitted keratolysis typically happens in individuals who are involved in wet work. So you will typically see it in swimmers, maids. So in individuals in whom their feet is constantly exposed to moisture or water for a long time. That because of that, what happens? There is infestation by Corynebacterium. The skin becomes soft, so it causes lysis of keratin, and this leads to these pits and maceration that happens. So typically, swimmers, maids would have it, and typically it will increase in hot, humid weather. And it would be quite a recurrent thing to happen, because you'll treat them again, they'll go into the water because their job demands that, and typically they'll have this thing. And if you see this, the insoles are relatively spared, because when you put your feet down, it is these curvature which comes directly in contact with floor and thus to water. Clear? So these are three common Corynebacterial infections. You should be able to identify them, and you should be able to know that these are Corynebacterial infections. The third common bacterial infection that is asked you is Pseudomonas skin infection. Now, Pseudomonas is something which you would see more commonly in diabetics. in patients who are admitted. So in patients who are immunocompromised because of any reason. So immunocompromised state may be because of some organ failure, patient on chemotherapy, HIV patients. So typically when they want to ask you about Pseudomonas skin infection in question, you will have some scenario like this. Because Pseudomonas usually will not affect healthy adults. It usually affects an individual who's more immunocompromised or is a diabetic or is in an inpatient setting where there are more chances of hospital-acquired infections. Now, Pseudomonas can lead to a lot of features. The common infections being it can cause green nail syndrome, where when you examine the nail of the patients, it's all green. This is because of Pseudomonas colonization in the nail, and this Pseudomonas releases a substance called as pyoverdin, which emits this greenish fluorescence. Pseudomonas can also cause interweb intertrigo. Now, interweb intertrigo, which is infection in between the web spaces, can be caused by tinea, can be caused by erythrasma. So, when a patient comes to you with interweb intertrigo, do a Woods lamp. When you do a Woods lamp in Pseudomonas infection, you see this greenish fluorescence. So, greenish fluorescence on Woods lamp in interweb intertrigo is characteristic of Pseudomonas infection. Then the third important infection which it can cause is called as hot tub folliculitis. Now, what is it? It is usually seen in individuals who have recently gone and taken bath in public pools or jacuzzis. Now, from that, they got infected with Pseudomonas, and typically it presents on trunk with monomorphic erythematous papules. So this is hot tub folliculitis. Hot tub because it typically happens after bathing in public pools, jacuzzis, or they went to a resort or somewhere. And then typically, just like folliculitis, you get monomorphic erythematous papules, which are present all over the trunk. So this is hot tub folliculitis and it is caused by Pseudomonas. Another question that has been asked. Then what else does Pseudomonas cause? Pseudomonas can cause eschar formation. Now, Pseudomonas is a bad bacteria to infect our skin. So, typically in immunocompromised individuals, it would start with hemorrhagic pustules and forms this eschar, which is nothing but a necrotic crust, deep necrotic, painful crust that you see in immunocompromised patients. You have to think of Pseudomonas infection. So, eschar is typical of Pseudomonas infection. So that brings us to the end of bacterial infections. These are some of the common bacterial infections that are asked. How do you manage these bacterial infections? So in bacterial infections, general measures become very, very important. Local hygiene has to be stressed on. If there is a crust that you see, try to remove the crust. You can use it, do it mechanically, or you can use potassium permanganate which is KMNO4 compresses. Then, if the infection is more severe or recurrent, you please eliminate any immunocompromised factors like is the patient diabetic, is the patient malnourished, is there any organ damage that's happening, is the patient on chemotherapy. So please rule out all the immunocompromising factors because otherwise your bacterial infection would be very, very recurrent and persistent. Topically, there are various agents that can be used. You can use bacitracin, polymyxin, neomycin, sodium fusidate, pramycetin, which is nothing but soframycin, which you commonly have at home, mupirocin, ratapamilin, and ozenoxacin. Ozenoxacin is a newer antibacterial topical agent which is available and is commonly being used. Can be asked because it's a newer agent. Commonly, what do we use? We use mupirocin or sodium fusidate, which is very, very commonly used for topical infections. Systemic infections we will employ when we have more diffuse infection, when we have deeper infections. Typically, we use beta-lactamase resistant penicillin. We can use methicillin, cloxacillin, dicloxacillin, amoxicillin. We can also combine it with clavulanic acid. Then erythromycin, cephalosporins, all these classes of oral antibiotics can be used. If a patient has recurrent infection, then what do? You rule out all the immunocompromising factors, and then there are three things that you can do. You can tell the patient to put intranasal mupirocin 1 week per month. So typically it is believed that the colonization by pathogenic bacteria starts from the nasal mucosa. So as a preventive measure, patient can put mupirocin in the nares, inside the nares 1 week per month to stop the growth of these pathogenic bacteria. The second thing that can be done is you can give clindamycin 300 milligram per day for 2 to 3 months. This also stops any unnecessary colonization that's happening. And the third thing is you can give rifampicin 600 milligram once a day for 10 days. So these are various therapies which are employed if the patient has recurrent infections. Thank you so much. That brings us to the end of this session. If there are any questions, I will be happy to answer them. I hope you enjoyed this session and we'll keep holding such webinars in future.